Hello, this is Glenn Krause from AE and Associates with our next podcast. Today we have the privilege of having Mark Johnson, and I'm so happy to have Mark. He's a practicing physician assistant in a very busy, very busy ER. Working. He has 19 years of experience in both the inpatient hospitalist as well as ED arena. Mark, why don't you introduce yourself? Thanks again for being on the podcast.
Yeah, Glenn, it's a pleasure to be here. Have been a PA now for almost 20 years. It's hard to believe. Spending most of that time in the emergency room, but happened to try out some hospital medicine, mainly as I worked with a company who worked on both sides of things. And when a contract had ended in the ER, they had continued with hospital medicine, and I had thought about trying it out. So I was changed over to that. It just happened to be during COVID.
Oh, wonderful time.
A crazy time to be doing that.
Right.
But it was a great experience. Other than that, I am back in the ER now, and in my free time, I have been working on a blog called PA for Life, and that's been something I talk a lot about, burnout with clinicians and how we can make things better for all providers, PAs, NPs, physicians, really anyone on the team.
That's good. Hey, I appreciate that. Hey, we've been talking a lot about documentation going back and forth, so I wanted to start out with you to get your thoughts on this. What would you say are the biggest challenges in provider documentation, and I like to refer to as communication of patient care that you face today? What do all providers? What are the biggest challenges? I hear a lot of physicians and PAs and NPs struggling with documentation, and what do they call it? They call it pajama time, spending time at home, relaxing in front of the computer instead of in front of their wife or family. So, what are your thoughts on the biggest challenges that at least you face?
Yeah, and thinking about that, there's a lot of challenges we have today, and so how do you get the greatest one? But I would say one of the greatest ones that I think that we face today is the electronic health record, which, looking back in my career, we used to use these. I don't know if you recall the T systems.
Oh yeah. The paper, check it off and yes or no.
Yeah,
right?
We checked off the boxes, and I was like, someday we'll be able to get on a computer and we can type this stuff, and I'm quick at typing, and our life's going to be so much easier, and we're going to be so complete, and I'll be able to look and see this guy's prior records, because now I got to get stuff faxed to me, and this is terrible, and someday medicine will be better. And now we have an electronic health record, and we look back and say, oh, remember the days of T-System? Weren't those great?
Yeah.
We didn't have to know as much stuff. We didn't have to go back and look all the stuff because it wasn't available. We'd just say, well, I guess this is AKI because I don't have a prior creatinine.
Yeah.
And the biggest things that we're facing is something as simple as ordering a Tylenol takes 1 million clicks. And these clicks in front of a computer are sucking our life away. And it's pretty rare to find any sort of provider who actually enjoys electronic health record, which, if you're talking to anyone, we pretty much know we're talking about Epic here because that's the main one.
It is.
And that's one that's just killing us some days, because going to see the patient is the fun part. Now we got to sit down, and now we got this monstrous task of putting together this big, beautiful chart, which takes a lot of work if you want to do it right.
So let me ask you a question. Do you have scribes in your ER?
We do not have scribes right now. I have previously worked with scribes. The biggest issue that I have seen with scribes is a lot of these people are training to move to do something else. They do go through some training, and some of them can be very good, but often once they are good, they move on to medical school or PA school, wherever they end up going.
Right.
A lot of them are not that great, and they end up writing charts full of fluff and smart phrases that are frankly useless. And so, yes, that can help you, but I often find myself fixing charts from the scribe, so it doesn't always help me whenever I have used a scribe.
Yeah, so listen, and I've had a conversation with a couple of doctors that feel the same way. and I wonder whether having these scribes become more vetted in documentation to get some education, just like residents should be on documentation, so they can point out, deficiencies or any areas of focus. It seems to me that my brother, they tried using scribes in their office, or in the ED they had scribes, and of course he's not an ED physician, but the scribes follow the consultants around. And he said just the same. He spends a lot of time just fixing what they communicate. He says, might do it themselves. Save him more time, because now I have to read something, then have to fix it. Just do it the first time yourself, right?
Absolutely. And I always said, if I'm going to use a scribe, then I personally want to sit down and teach that scribe how I want things done. But it's crazy because a lot of times I would work with physicians and they didn't want to hurt their feelings because the chart sucked. And so they just would fix the problems. And I'm thinking, I know these people don't make a lot of money, but you're paying this company a certain amount of money. Right. They're not getting all of that money. The company is making good money here. And you're not getting the product that you're looking for. So if you're going to use scribes, train them exactly how you want things to be done. Tell them this is what I expect when the chart's done, because there's no way I'm going to have a scribe and then have to redo the work. It's just, it's supposed to be a time saver, but unfortunately, a lot of them are not trained well enough to really make it how it sounds, because it sounds great. It sounds like, hey, I got somebody following me, putting together this beautiful chart. They think of all these things, but the problem is they're not thinking of these things. They're putting in all these fluff words, and they come up with a chart. But when you really look at it, it's just a lot of lines. But you're like, this is what every chart looks like, and all the charts start looking the same.
And then you kind of wonder from the OIG's perspective, or any payer, this looks like clone documentation.
It absolutely does.
And clone documentation, according to Medicare, when they see excessive copy or paste or clone documentation, they emphatically state that this type of documentation does not meet medical necessity, and they won't pay. So you're kind of caught between a rock and a hard place on that. So let's move on to my next topic. What are the most limiting factors to providers effectively documenting the ED and on the hospital floor? You spend some time on the hospital floor. So once again, what are the most... There's a lot of limiting factors, right? Like interruptions and being paged and got to go down to the ER to admit a patient. So what do you think is the most limiting factor? Or let's say top 2 or 3, do you think?
Well, there's a lot of them. And actually... you bring up interruptions. I might start there because that's not one that I actually had thought of, but absolutely interruptions are a big deal because I remember going to, this has been several years back, going to a hospital provided dinner about burnout, and one was about interruptions and how when you go to work, a lot of times you just need to turn off your ringer on your phone so that you're not trying to respond to things during your shift. But let's say I am doing that and I'm not responding to anything personal. I'm staying off my phone. Well, now Epic has an Epic chat thing, and now people can send you messages throughout your shift. In ER, it's not as big of a deal, but in hospital medicine, you talk to those providers today, and this started a year or two ago. It started out as a great thing. Hey, I can get a hold of the nurse. I don't have to pick up the phone. I can just tell them, hey, could you do this? That's fine.
Yeah.
Now doctors are getting message after message. So-and-so's got a fever. Can I order Tylenol? Well, there's PRN Tylenol ordered, so
why are you asking
why did you need to send me a message? And if you respond, a lot of times they're like, well, you're so nice, I just want to send you a message. Well, and a lot of times it's well-meaning people, or else they're like, hey, so-and-so has a question about this, and a lot of it's well-meaning things that may need to be addressed, but most of it is not urgent things that have to be addressed, and you're getting interrupted multiple times.
Yeah.
During your day. You're trying to get some things done, and what's happening is you're getting pulled away from something you're in the middle of, and now you finish that. Okay, now I'm going to get back to my chart, but you've lost your train of thought now.
Yeah.
Imagine that happening 4 or 5 times while you're trying to do just simple one note. And now imagine how many patients you have to see during the shift. And we're not even talking about all of the maybe the pages or everything else that is happening, or else peer review calls or these other things. So Interruptions, absolutely a big deal. I would definitely say the time that we really feel like we need to do charts, we just don't have it because we have more patients to see, and there's always that push to see more patients. The more patients you see, the more you make for the company or the
Yeah,
hospital,
that's right.
and because of cuts in payments, that's the way that they're trying to make up for it. But that doesn't always work very well. And when I hear people saying, well, I went home and spent 2 hours working on my documentation, there's a problem. There is a big problem. So that's something that has to be addressed, because that can't be a regular thing. That could be maybe once in a while, you got stuck late, whatever happened. That's going to happen sometimes. But I talk to too many people that this has become a regular thing, and now it's an expectation. And so companies are like, well, I guess this is working just fine. Well, it's working fine, but you don't know what's happening after hours. And that's something that should never be sacrificed, in my opinion.
Absolutely, because that your one of your mantras is burnout. I can relate to that. I've been working hard to build my business, and I work every day. And sometimes say, is it worth it? I come downstairs to my office and say, oh, another day, right? Let's get this thing over with, right? Where other days are more exciting. The other thing is how now that you told us what some of your challenges. I think it represents all providers. How best do you overcome these challenges in your practice? Okay, you've been in the ED how many years now, Mark?
Yeah, almost 20. Well, it's constantly evolving, and it's something that I'm learning to do. And just when I think I got to figure it out, something changes, and I have to rethink things. But a few things that come to mind would be, even though documenting the room can be a bad experience for the patient, if the provider is sitting in front of the computer just typing and I'm looking at the patient,
Yeah.
I think it actually can be a good experience. Often I will walk in the room and tell the patient, hey, could I bring up your chart for just a minute? And they're like, okay, that's fine. I'll bring up the chart, and I say, can you confirm your name? Okay, this is my name. Okay, all right. So, and before I've gone in there, I've tried to take some time to look through their chart and said, okay, so I understand you have diabetes, you've had a blood clot in your lung, you had a heart attack last year, and you came in today because you're short of breath. Is that? And then I do my very best to let them talk and not interrupt them. And as they're talking, I'm also looking back and forth between the patient and the computer and trying to type this stuff now, so that when I get back to the desk, I don't have to go and dictate all of this. Sometimes I'll write notes and then go back and dictate. But if I'm able to get some of the information, I'll put it together so that once I'm done with my exam, I can sit down and say, okay, well, let me just go over everything. Here's what you're telling me. And there's been several times where they'll say, well, no, actually, I told you last week, but it really started a couple months ago. Okay, well, that's a big deal. So you're saying it started a couple months ago, but now it's worse. Yes, okay. Well, that changed some of the story there. So that's helpful, so that when I go back to my desk, I'm not starting from scratch.
Right.
So the other thing I've already mentioned was spending that few minutes before you go to see the patient. If it's a 20-year-old with no medical problems, okay, it's strep throat. If it's a 20-year-old who's been to urgent care 4 times and he's been treated with 3 different antibiotics and now he's getting a lot worse, now we know walking into the room that you're going to be treating this workup a lot differently. We'll probably have to do labs. We'll probably have to do IV. We'll have to do additional testing, maybe a CT scan of the neck to look for peritonsillar abscess or whatever. So getting it in that context, or maybe they're immunocompromised. Knowing that ahead of time really can be helpful. And I use caution with this, but often smart phrases, smart lists, templates can be very helpful as long as they're created for you in a way that it's going to be useful for you. And I've made good smart phrases. I've made bad smart phrases. Again, my thought is if this is something that I'm typing over and over every single day, well, maybe I should make a smart phrase for that so that I can put that information in. It's exactly what I want it to say. and then I can modify it based on that patient, well, that's a good smart phrase. But if I have to go in there and change half of it every time, that's not a good smart phrase. So there are some things that you can do, or smart lists where you can go and patient comes in with flu-like symptoms and you can click on every single one of the symptoms that person has. Or just a template where you have everything kind of lined up the way you wanted. I think those are some things that can be helpful.
Have you ever, this was great information you're sharing, Mark. Have you ever seen any or heard of any your colleagues who've had a CDI program, the ED? Are you familiar with any of them programs?
I'm not actually. In what way do you mean, Glenn?
Well, I think some hospitals have CDI programs that I'm aware of in the ED. They're looking to capture diagnosis to start with in the ED, okay? Because if you talk about present on admission, present on admission indicators in inpatient setting, you certainly want to have some projection of, okay, was this symptomatology, was this diagnosis present on admission based on the patient's symptoms, doctor's observation, finding, results of labs, radiology tests, history of present illness, and so forth. So I see some hospitals having CDI programs in the ED, but once again, they're focusing on the reimbursement. And so I can see, I've worked at a facility where we have CDI in the ED, but it was basically in the right format to the extent that the CDI person focused on, okay, do we have a good patient story? Do we have a correlation between the ambulance run sheet and the history of present illness? Because obviously, when you have a patient that comes in, Mark, brought in by ambulance, you get a copy of the ambulance sheet, right, run sheet, and if they've done any EKGs or if they administered oxygen per the conversation with the ED. That's crucial and vital. That should be included in the physician or provider's documentation. Patient brought in by ambulance, blah, blah, blah. Picked up, this is what they look like. Because it forms a nice novel. Remember, the medical record was supposed to read like a novel, right? You got an introduction, you got a body, you got a conclusion. So when I worked... go ahead.
Well, the challenges we have, Glenn, first off, there's not enough. There's very little time that I've actually spent with CDI folks from the ER. Now, when I got in hospital medicine, I think there was maybe a little more time. But the challenges to some of the things you just said was, for one, example this week, I needed an EMS report. Like I need a little more information on this patient.
Right.
We have an EMS report.
Okay.
It took I don't know, forever for us to find this EMS report, because by the time we get that EMS report, the patient's often already admitted to the hospital. And it's like, well, it would have been nice to know all this extra information, but the EMS crews, I guess, with their electronic health record, takes a while to get all that done until it's finished, and then it gets faxed to us, and hopefully that fax gets to us. But I would say the majority of the time we don't see that report. We just get the verbal report, which may not include a lot of those details.
Yeah, I can see what you're saying. And it should be really, if you have CDI and the ED, it's more to me of education, okay? If I see, like right now, I'm going to be starting a project in North Carolina, okay? They had a CDI program for years. It hasn't moved the needle on documentation integrity. They're getting more denials for, clinical validation denials, status downgrades, medical necessity denials, recoupment 6 months later. Okay, so I think it really goes back to, okay, who can really improve the documentation? The physician assistant, the nurse practitioner, right? The physician. It's not necessarily CDI. They should have the wherewithal to review charts and be able to provide feedback, right, in real time, not 6 months later, or use the documentation as a way to say, okay, before we started, I read you that history of present illness in the office, right? We were scratching our heads wondering why the patient's being seen. So that's the kind of feedback that I like to provide to residents, and at least in the outpatient and in the inpatient, because you don't want to continue to get queries. You want to do it right the first time. And I think we have a topic on that in just a minute, right?
Well, yeah, I think here's the deal. All my career, I've gotten message from these people, who I don't know who they are. There's some individuals that are somewhere. They could be across the country,
That's right. Yep.
or they could be across the world. I have no idea who they are. I might respond to them. I might even respond to them in a not very nice way. I actually have been always nice to them, but some of the docs get very angry. And you might get a response and you're like, these people just don't get my job. They don't understand. Like they're asking these questions, and there's not a relationship there. It's just some person. When you don't have a relationship,
right.
You're like, why are these people important, and why are they bugging me, and why do they keep sending me these darn queries? I keep declining them, and they keep resending them, but there's no explanation. And if there is, it's maybe it turns into a nastygram, and you're trying to figure out, like, what are they trying to figure out here? And so that all comes back to, you can't just make this better by keep sending messages like queries, because the person might learn from that, but often they don't. They just keep on saying, well, if there's a problem, they'll just ask me about it. And that's not the goal of it. The goal is educating, teaching, making it better, and that's a partnership.
And I think that that certainly evolves into our next discussion. I think what role does CDI play in working with providers to help them achieve better, more effective documentation? And you've already touched base on some of them already. Repetitive queries does not help.
Well, I think one thing that I will say that I got an email from my company a couple of weeks ago.
Yep.
And they said, since we have the new guidelines, we reviewed 5 of your charts, and they looked really good.
Great.
I forget one of the things they said I could maybe change. I forget what it was. It was something minor, but that was actually good feedback. That's probably more feedback than I've gotten, honestly, in years. But that's something that I feel like needs to be an ongoing thing. And I personally need to hear what I'm doing right, because if I hear I'm doing really well with my documentation, I'm patting myself in the back.
You should be.
And then I'm actually asking myself, well, maybe there's something I could do even better. What is it that maybe, where am I lacking? And that's also something I want to hear about. But please don't only tell me about the stuff I'm doing bad. I really need to hear what's going right with my charts. So let's keep doing that. Where are the areas that we can improve? And maybe I know this stuff, but I need to know from the perspective of insurance companies how it needs to be documented in order for us to be reimbursed correctly. That may be something that we need to be re-educated on, or else I just need to document differently than I currently am.
And I think it really goes back to you hit the nail on the head. Queries does not help. It just agitates. And Dr. Martin, Jake Martin, who I work with for 27 years now, says it's not a real word, but he says educate, do not queryate, because queryate doesn't change behavior. I was on LinkedIn and someone was saying they're using the queries as education, and I said no. Queries is not education. It's reactive, transactional, repetitive, and physicians will still get the same query because they don't, like you said, they don't know what to write or why you're asking, so they'll just wait for another query. Well, I'd get kind of agitated if I had 10 queries after a rough day on the floor, and I have, let's say, 25 patients because I'm short a hospitalist. I'm getting killed with admissions because it's my day to admit patients, and I come back at 6:45 thinking I'm going home at 7, and I got 10 queries. I don't think I could handle that. I'd rather, to me, my goal as a CDI it aligns with what you're thinking and what you expect. Be on the floor if you're practicing on the floor, and actually providing educational tips to say maybe next time you may want to consider this, or your HPI can be tightened up. It has 20 sentences. We can tighten it up to about 8 or 7. Okay, physicians want.
Well, and some of the things are just stupid. I'm not sure if that's an epic thing, but it's you'll be actually halfway in your visit of seeing the patient, and
Yeah,
they'll say, "Well, you don't have your history and physical." And I'd literally type a message back. This has been a couple years back. I'd say, "I'm seeing the patient still. I haven't even finished seeing the patient. Give me a break." Again, this is more interruptions in my day. You're not helping me to remind me. I realize I have charts to do. I don't need you to remind me about that. And it's like you remind me of stupid stuff, but I actually would like feedback on some of these important issues. So tell me on these charts. Tell me every month, review so many charts and say, hey, I reviewed these charts. Everything's looking great. I really like the way you do X, Y, and Z. One area that I think you could improve is this.
yeah.
And I'm not sure if they're afraid to do that because then it turns into I'm going to tell you these things so that we can ask for more money or try to get more money out of this chart, because I don't think that's the goal of any of us. But for me, I want to make sure, hey, if I need to document things, I feel like this is a great chart, but what is it that from on the outside, you're looking at it and maybe you're missing the part that I feel like is there, but you don't feel like it's there, and I'm not telling that enough of that story. So maybe that's something I can work on. That's effective communication.
It is.
And it turns into that now we're working together. It's not like you're our foes. And that's kind of the next thing I was going to talk about. Too long it's been that when we do have to talk to these people, it's like when we were in school and we had to go to the principal's office and you did something wrong. You're not really sure exactly what. Maybe you are sure what, but it's not a good feeling. Instead, I think it should be you're meeting with a friend of yours who you know is trying to help you in every way they can, trying to make your life easier. And yes, we are trying to get to the same goal, but what can I do to make your life easier? How could I help you? And that's where the real partnership comes in.
Yeah, so that brings us up, and that's the key word, Mark, partnership, which leads to my next topic. What are you expecting from CDI? Let's say you're still working on the floor, and you're familiar with CDI. What are you expecting from CDI to help improve your documentation and communication in the EHR? It's what Dr. Cutler, who's still practicing hospitalist, says, helping the provider work smarter, not harder, as Mike. So what can CDI do? Picture yourself back on the floor. How can they help you become more efficient working in the communicating in the EHR, working smarter, not harder. So you're not practicing pajama time with your documentation at home.
Well, simple things like if you show up randomly in the middle of my shift while I'm trying to see patients or trying to do some things, that's not good time to talk about it, and I'm probably going to be pretty irritable. So maybe ask me, hey, when is a good time we could sit down? I'd like to go over these charts with you.
Okay.
But it needs to be more than just I want to go over the charts. It's like, hey, I want to review these with you, and I think some of these look great. I really want to talk to you about how great you're doing. If they don't look great, just say, hey, I'd like to meet. We can talk about some things that I had some ideas for, but it really needs to be something that we become more of friends than foes, because too long it's been I'm gonna basically tell you what you're doing wrong, and I'm gonna get as a provider I'm gonna get really pissed off about it. And guess what? When people get pissed off about it and they feel nagged, it doesn't change their behavior.
No.
They just some people will just automatically not do it just because you told them to, and some doctors can be very stubborn people. You know how it is. It's like I talk to patients about any sort of addiction. I look at the spouse and I say, I know you're concerned about their cholesterol, but it doesn't help you asking them every 5 minutes, why are you eating ice cream? Why are you doing that? It does not help. I said, well, and I say it in a nice way. I said, the best way you can do is you can say, I'm concerned about you, but you have to make your own decisions. And guess what? The person who has the addiction knows they have a problem. So they don't need to be reminded. And the more you nag, the more they're probably going to do that addiction. Whereas if you stand back and say, listen, you got to make your own decisions. I'm not very happy about it. I'll support you no matter what, but I'm concerned. Then that puts more of the onus on the patient, or in this case, the provider, to say, okay, well, maybe I could get a little better at this. What is something that I am going to do? So now I'm not being nagged. I am taking charge of this issue. Um, and, it changes the whole thing. And I think taking personal responsibility for it with the support that you need is really the most important thing, because you could have the smartest, best CDI, and they can know everything, but you're not going to win by cramming this down someone's throat. You have to come across as people who are going to be supportive and saying, listen, I know you're overwhelmed with work. I don't want to make any more work for you. In fact, I want to make your job easier.
Right.
Through this partnership, I think we can make that happen. It might take a while, but the last thing I'm going to do is add more to your plate. I want to make it easier for you. And that's a whole different conversation. Us in medicine, we're looking for anyone who's willing to help us these days.
That's my objective. Hey, Mike, you remember a couple of months ago you were talking about a CDI providing education. What did you call it? A snooze? What did you call it? I think you called it a snooze fest, didn't you?
Yeah, a snooze fest. So
elaborate.
Yeah, so let's get on a phone call. Okay, well, this should be interesting. Let's figure things out. And then it's like, okay, today we're going to talk about CHF. Okay, well, we deal with CHF,
all the
and
time.
then it's like, all of a sudden you're just like, okay, they're just reading off the slides here, and who is this person talking, and do they actually understand what they're talking about? Do they understand the situation that I'm currently working in? And have they looked at my charts? Because I haven't gotten any feedback. Are they talking about me, or are they talking about someone else? Maybe I'm actually the one who's doing great and the other guy's not, but there's no personalization in it. It's just, I'm just going to read off a screen, and that's not helpful. And honestly, most of the time we just tune it out or turn it off. You get to the point where you're like, okay, I physically was there, but my mind was not there. I was doing 500 other things because it's not practical to me. I'm not hearing what I'm doing right or wrong. I'm hearing you talk to a group, and I don't know how this even applies to me. So it takes more work really to have it more personalized. But at the same time, that feedback really changes things, in my opinion.
Yeah, it sure does. And that's why I really focus, or the CDI, I should say, should be focusing on that one-on-one educational. 5 minutes here, 5 minutes there, schedule ahead of time. Hey, I got a tip for you. Which leads me to my next question, or my topic, is Dr. Jake Martin, a longtime colleague of mine. You have spoken to him in the past. He mentions this. He reminds me all the time when we present. He says physicians want and can use tools in their toolbox to affect positive change in their behavior of documentation. So as a provider, Mark, what types of tools or resources do you think most providers want in their toolbox so they can work smarter, not harder, and make that transition to a better communicator and documenter of patient care? So is it tip sheets? Is it newsletters? Is it 2-minute what I call 2-minute drive-by consult? Say, hey, left you a note, or you may want to consider this, or great job. I like to give compliments when necessary or when appropriate, because providers generally do not receive compliments. They only get notified when they're not doing something right, correct?
Yeah, I mean, I think that's a big one. I think just hearing some of the positives, because unfortunately, and we're kind of trained to figure out, the bad stuff and the negative stuff. But when we hear 99 great things, but one bad thing, we usually focus on that one bad thing. And so we need to hear ongoing positive feedback. And the negative feedback doesn't necessarily have to be punitive. It just has to be, hey, this is something that we need to work on. Is there a way to help you with that? And some simple things would be maybe helping them with a smart phrase, help them create it. It doesn't have to be something that you made for like everyone in the group per se, but maybe asking them, would you like to make a smart phrase to include all these things? And what would you like to include? And everyone charts differently, does things differently. That takes a little extra time, but those little things, it's like, wow, now I can use this every time I have a CHF patient, and it reminds me these are the things that I need to address every time, and this is how I'm going to have my chart set up. But most people don't have time on their day off, nor do they want to spend time in an electronic health record. People just don't want to do it. I think it is a good investment of time if you're able to, and I personally have spent some time this year trying to sit down and make some changes in the electronic health record, because it's kind of like some small investments up front really pays off in dividends later. And that's something I do for myself. But from CDI perspective, it's just someone to say, hey, I could maybe help you with this, or what would help you? Would it help to have a tip sheet nearby? And everyone might respond differently. I guess it would depend on how everyone wants it. It needs to be customizable based on how the group practices and what their likes are. In my opinion, you could have a great program for CDI, but you're going to have to modify it with every group that you see, because the message won't be the same for every single time. So it's not always cookie cutter, which again makes it a little more difficult. But if you're communicating effectively, that's when you're really going to start to see some change.
Right, and I agree. You're gonna the CDI program working with the providers, and as you said previously, ongoing conversations, not like every 2 months have a snooze. What do you call it? Snooze fest.
Every 2 months, that would be frequent, Glenn. We're talking like once every 2 years, or never. Yeah. Yeah, and then when you do have conversations, let's make them, not 2 or 3 hours. Let's or send me information, or even if it was an email. Hey, I reviewed 10 of your charts. Here are the scenarios. Here's what we saw. Here are some positives. Here are some things to work on. If you'd like to discuss any of this, I'm available. Here's my hours. Let's talk about it. I'm here to help in any way I can. That to me is very helpful, and that didn't take a lot of time from the CDA program per se. Those phone calls for follow-up then works around their schedule, which again is not very cookie cutter, and sometimes that can be difficult to arrange for everybody, but you want to make sure that you are having those follow-up conversations, because that's where people feel like, hey, this person actually is on my side. They're not just here to nag me about something.
Right, and that really, Mark, would you agree that that's why we need to really get away from the query, just query as a basis for CDI?
Absolutely. Queries, I suppose, serve their purpose, like, hey, you forgot this. But too long it's been query. I start my shift, and there's a lot of people who are just like, I'll throw something in there just because they want me to. But it's not effective. It's what they've tried to do for way too long. It's not effective. It can be something occasional, but when that's all you're depending on, it's not going to be effective as having a relationship, because again, most of the time you get these queries, I have no idea who sent this to me, and frankly, I don't really care. I just want to get through them so I can get all these things out of my in-basket.
Excellent point, Mark. This has been great. Any final thoughts or ideas you want to share with our audience?
Well, I just really, you talked about Dr. Cutler, Dr. Martin, and yourself. I always enjoy having conversations with you guys, because you guys each bring such great perspective. And these are things that I get excited about, because I think there is a better way of doing things. And even though the electronic health record some days just feels so overwhelming, I do think that it can get better, but it's going to take a lot of people working together to make this happen. And also, putting together a great chart doesn't have to be a total overwhelm, but it does take some ongoing conversations, relationships to make these charts great so that you can be proud of the work that you do.
Absolutely. That's great. Mark, you've been wonderful. You had shared some excellent points. So this concludes our podcast. Mark, thank you very much once again for taking time out of your day off from the ER. Much appreciated. And I wish you good luck. And thanks again, everyone. Take care.
Take care.